I'd like to kind of focus on one or two key instances, alternative payment arrangements that you were instrumental in designing, implementing, maybe both.
Yeah, so I've done a number of these arrangements, and again, both on the provider and the payer side. You know, from the payer perspective, as you design a reimbursement structure, and look, the payer, despite the fact that, you know, I think they would say we have a role in enabling workflows and a whole host of other things around clinical delivery, the most important piece in my mind is getting the payment structure correct. Making sure that they understand the incentives that motivate the provider, that they're appropriately incenting and rewarding the provider for outcomes. So I've worked with a local Blues plan. They're in multi-states, but they are not a national plan, and thinking about their value-based care strategy. And you know, the first thing that we did as we thought about the program was, what were the aims and objectives? What were they trying to accomplish? And then really thinking critically about how many of their providers are ready, right? So I call this a path to risk strategy, where you're thinking through and you're actually, I'll just say, stage gating the providers based on maturity. And the incentive model, the reimbursement model needs to change as they mature and as they grow through and achieve outcomes, in all honesty. The first piece is just, what are those components, right? So you can start from a minimum of, we pay for performance, or some upside incentives. Could be for data. That's an easy way to start data flows and understanding of parties. Could be on certain metrics, whether they're clinical admin metrics or some outcome metrics related to a population. And moving forth into greater incentives, we typically call that upside only, right? You achieve certain outcome metrics, and therefore you get a greater share of either the savings or the reimbursement. I don't think there's one that's better or worse. We see kind of both of those models. And then moving into upside downside. So the difference between what I call kind of a true capitation model versus upside downside is the risk is capped. So it's within a form of guardrail that is defined and agreed to. And so each of those are really critical. The other piece that I would say is, it's not just the monetary components of it, it's what are the metrics and outcomes that determine when you're ready to go to the next stage. So that's really on the payer side. A lot of the work and the focus happens there to define that. And then what I would say back to the slotting is, how do you think through your provider network and who's really ready to come to the table, not just from a readiness perspective, but from an importance perspective for your members and your network, right? So that's how we think about that on the payer side at the highest level, and happy to go into more detail.
Well, I wanted to ask, I think, a couple of sub-questions there. One, you talked about readiness, and there's a lot of it in the literature. What does that really look like? I'm imagining you're at a table with your payer or with their key providers in the network. How do you gauge where they are on that continuum of readiness for risk?
So it's different for a provider than for a payer. I do think for a payer, they have to realize that going on this journey actually means some critical decisions about their provider network and their enablement capabilities, and honestly, how they're investing in their network. So I'll just contrast again, when I started, really what you thought about your network was broad and deep discount, right? You wanted a cost advantage. We are not into full maturity of a value-based network or high-performing network, but when we get there, broad and low cost isn't going to be the name of the game. It's going to be high quality, targeted outcomes, and cost, right? So cost isn't going away, it's just going to be characterized differently. So when I come to the table with payers in particular, you know, I want them to kind of be starting to talk about their network in a way that's different than just everyone's in, and really talking about the value creation that they anticipate and communicating that with their providers as well. Depending on the market, the payer is sometimes in a position to lead and should. Sometimes that's not the case, right? And so you also have to have some sensitivity towards that. And I encourage my clients to really think about their negotiation position as they go into these conversations. Just because you are not in a position to really drive the end-to-end doesn't mean you can't create value and you can't be leading. So for the payer, that is how I think about it. On the provider side, readiness is, I think, a much more complicated question. Because for the provider, truly to enable value-based care, you have to clinically transform. You have to transform the way in which you deliver care. You have to transform the way in which you're incenting your workforce. You probably have to change your clinical teams. You have to change your engagement with your members or your patients. And so that is a much harder question to say what is readiness. I think having the provider come to the table is the first step always. I've seen, and this will change, but historically, primary care physicians much more able, capable, and interested in coming to the table around these arrangements. We're starting to see some specialty groups also do that. Hospitals have been a little more difficult. The economic model is fundamentally, I don't want to say at odds, but at odds, right? Yes. That requires a whole host of change from the leadership all the way down. And so if I think about that just from the, who's ready, when I see a primary care physician come to the table and actually be able to articulate how they think about care, how they think about tracking outcomes, how they think about care teams, that's a really good indicator that they are ready. They're probably not done, but they are at least ready to engage the conversation. And then just the last piece is, as I think about these dialogues, it's a recognition of gaps and weaknesses. If two sides of the table are saying, we've got this completely figured out, don't worry, maybe except with the exception of South Florida and certain markets, but I like to hear people say, we don't understand this and we know it's important, and so we want to work on it together. Or can you help me do this, right? On either side. That to me is really important to creating a true partnership and enabling a journey versus a transactional, encounter or relationship.
Sounds like a couple of the subcomponents. One is the technical readiness. So do they need a certain EMR, or what is needed to be able to get the data with which to manage?
This is my own, I think, bias. I'm not a proponent that technology is the panacea. I think we in healthcare get really distracted on shiny new toys, and we believe that it solves all of our problems. To me, yes, there is, an EMR component, there's a workflow component. The reality is when you are delivering care, you're not going to be logging into 5 different systems in order to complete whatever you're doing. So making sure that the interactions, the prompts, and the pieces of data that need to be collected are done within a single system as seamlessly as possible, it is always the answer. But I've seen practices, and again, this is not recent, but practices that don't have heavy technology. They are using huddling strategies. They're using kind of who's on first, a very clear handoffs and workflows, and who's the care team lead versus when does the handoff occur? How do we think about the patient? Are we following up with the patient after a certain amount of time, right? Some of these things are just process and care delivery oriented. And so I think it's a mix, right? But to your question, I think it ultimately comes down to the commitment to change how you deliver care, right? And technology is part of that, for sure. But I think the bigger part is the people in the process and aligning that first, and then saying, what are the technology components that are needed? So EMR for sure, scheduling for sure, data, things within Medicare like risk adjustment and STARS performance are going to be really important, but also connectivity into the community too, right? So that's kind of an area where I also think there's more opportunity for us to really think through how do we kind of manage a member in all sites of care, clinic, community, and home.
Let's make sure we circle back to that in a little bit. But I'm glad to hear you say that it doesn't have to be a fancy EMR, because this research and this film series, we're spanning multiple countries. Yep. And the dynamic of EMR adoption, especially among different subsectors of healthcare, it varies radically.
Yeah.
And so it's good to hear this is not insurmountable if you don't have the latest instance of the most expensive EMR.
And I think, look, the EMR question is, I think some of the younger physicians that are coming up it's not even that they're more tech savvy. I think they're just more comfortable with technology, right? That's been part of their lives. But that doesn't mean that an older provider, a decade away from retirement, can't manage care. It's down to the clinician and the clinical asset and the admin asset within the provider practice, that all of them have to understand what the objectives are. Then they can work to achieve it, even without the latest instance of the new fancy EMR.
Well, that leads again to another nice sub-question, which you talked about workflows.
Yeah.
And now you're talking about all the different individual things that physicians do. Unpack that idea about workflows and what needs to really shift, whether it's a primary care office or some specialty involved with chronic disease or something.
Yeah, so I think back to your first question about reimbursement, right? If you go in, I'm sure you've appreciated this, go into any physician office and you sit for hopefully less than 20 minutes before you see your doctor. The nurse comes in, takes a certain amount of vitals, puts it into the system. Your doctor comes in, she talks to you for 5 minutes, 10 minutes, answers your question and leaves, right? So the first thing is we need to break that transactional cycle of how you visit patients. There's a whole host of things, and so keep me honest about this, but I even think thinking through the stratification of your patient population. So I joke, you shouldn't ever see me unless I have an acute need. I'm young, I'm healthy, I have a number of specialists that I go to for, different things that I'm managing, but on a day-to-day basis, I'm not in need of primary care. I'll contrast that with my godfather, who is a diabetic. He is an amputee. He has had cancer in his past, overweight. So he starts to become a very different type of risk profile and honestly needs far more intensive clinical intervention on a more regular basis in contrast to me. So I think first of all is understanding that population and understanding what the needs really are, and then aligning your resourcing to that. So if you are in, let's just say, a high intensity frail elder care model, right, maybe within a DSNP, dual special needs program population, you are going to be seeing far fewer people with far greater frequency versus a young and healthy population, one like a concierge primary care, One Medical, for example, that you pay, and they're targeting individuals like me to say, let's keep you in wellness and health, right? So it's a different philosophy on how that happens. And then from a workflow perspective, I think you need to then align that workflow to those populations. So you have to maintain, an understanding of the clinical disease states. One of the things that as a payer person, or thinking through the payer lens, is we think about a member within a context of you're a diabetic, you have COPD, you are overweight, you have had this, and I say it's vertical, right? It's along a clinical disease state versus the whole person. And so I think one of the things is that from the workflow perspective is the whole person then redefines what that workflow is. And it's having those conversations, it's having those opportunities, it's saying, are you managing these conditions in a way that holistically leads you to health versus are you taking your insulin? Have you checked your rates of this? How much have you exercised in the past week, right? It's actually thinking about them in a different way than categories that are kind of siloed and one-off. And the last piece, and I promise I'll let you ask your next question, is I think we need to figure out a way to engage the patient or the member. I joke we don't have healthcare in the United States, we really have sick care. And part of that is because consumers are really uncomfortable talking about their health. They're really uncomfortable engaging with the fact that their behaviors have consequences. It's not easy to be healthy, right? We have around us all the time reasons why we can be less healthy. But I think that that's the last part of this around value-based care. It's one that I don't have an answer for you. I wish I did. But it's the last piece where I say when we can kind of put the payer and the provider in incentives and outcomes together, and I think we're getting ever closer. That is good. It's going to go a long way. The patient and the member is the last piece, and it's one that I don't feel we have even started to kind of crack in any material way.
That expanded nicely on the workflow question, but I wanted to follow up on that because I'm just envisioning, let's say you walk into the office and I'm a physician in a big clinic, and maybe contrast prevalent work behaviors now or practice behaviors now with what you explained. What you explained sounded great, but I thought that's what everybody's doing. Don't they all look for their diabetics? Admin, pull me a report of all of our diabetics and then let's see if they've had all their screenings. Is that not happening and you come in and help them understand how they just need to do different analysis or be help me understand?
Yeah, it could be. I in no way, shape, or form want to imply that physicians aren't looking after their patients in the best way that they think they can, right? Having said that, let's just say I am a diabetic. If I'm not going to the doctor on a regular basis, or I'm not on insulin, maybe I'm pre-diabetic, right? But I'm not managing that condition, the doctor, in all fairness to her, has no way of engaging with me and helping me and preventing disease. This is why I say the consumer, the member, the patient, the consumer is such a key part of this, right? So within the walls of the clinic, when I'm there, I am getting the care that I need within the scope of what I'm telling the doctor. But if I'm not there, how do I access that, right? Again, and how do I proactively understand what could be happening, right? But I'm not having the conversation with my physician on a regular basis to say, let's go get my cholesterol screened. Let's go do this. I have a history of these things in my family. Should I be thinking about them? And that's on me. I don't think that my clinician should be, expected to do that in every instance, but that's the type of dialogue that we need to have. And again, as I think about the promise of a different type of care intervention and reimbursement, that ultimately is where I think we want to go, right? It would be on managing diseases existing today in a better, more holistic and compassionate way, and allowing clinicians to practice medicine, in all honesty, and allowing the payers to really incent for outcomes and drive better quality and lower cost. But ultimately, you do want to then have a dialogue and be thinking about not only today, but tomorrow.
Part of what I think I might have heard was a passive connectivity to the patient, where are most physicians waiting to hear from a patient who needs to be seen.
Yeah.
Needs as defined by that patient, his or her family, whereas the model you're describing sounds more proactive. We identify somebody who likely needs consultation, guidance, proactive help, reach out to them and get them in. And the Melinda Durrs of the world, who are fit and fancy and great, maybe we send you the annual reminder, you need to come in for that annual check, and that's it.
Or I see a nurse practitioner, or I go to a minute clinic, or a specialist is, kind of the focus of what I'm doing. I mean, I'll say novel, it's not novel in the sense that but when I heard it, I went, oh wow, like the commitment on the physician side, this is a physician intervention, was actually, it showed me that they were pretty serious about what they were doing. So it's a clinic in South Florida. They do Medicare and Medicaid patients. They see that population with a little bit of commercial, but they require every one of their attributed patients on their panel to be seen once a quarter at minimum. So if you don't schedule, you get a call. You need to come in, the doctor would like to see you, or the nurse practitioner. If you miss, you get a warning. If you miss 2, they basically take you off the panel. And the reason why they say that is our commitment is to health. So your commitment has to be to health as well. And so they have an implicit agreement that the doctor is going to see them at some regular interval. And again, these are members with health needs, right? So they are a higher acuity population to begin with. But their philosophy is, I can't help when I don't see you. Again, you would go, wow, they've asked patients to leave their practice. But it's because of a misalignment between their philosophical approach to care and what the member needs, right? So in that, when you flip it around, I think that's actually incredibly impactful, both for the physicians and for the member to say, this isn't what you want, and that's okay, but no, this is what we give, and you're not willing to kind of meet us where we need you to be, and therefore it's not the right match for us. So I've always kind of looked at that as, when I first heard it, I kind of had a very strong, why would you do that? And then thinking about it more, I actually go, no, that completely makes sense, because they're asking of their patients to come and participate, and that's a requirement that they need and ultimately to be successful.
And I can imagine, in addition, that would be very motivating for patients, particularly in a market that has a physician shortage.
Yeah.
Where I need a doctor, and if my doctor, quote unquote, fires me, then I'll be in the lurch, and I occasionally need a doctor, so I better do what I'm told, or better cooperate.
And you can see now,
collaborate.
Even things like digital telehealth and digital engagement, right? So you could actually do this in a very seamless and non-invasive way, right? So if I don't need to see the doctor, hey, it's just my quarterly checkup, how's things going, what are you doing, blah, blah, blah. You need to prepare for this test, or let me schedule this test for you. I think some interesting things around telehealth are actually really interesting in how you can maintain connectivity while not being within the 4 walls of the office.
Well, and that has been a good learning or capacity building from the pandemic. Kind of forced us, we already had the technology, but it forced behavior change.
I hope so. One of the things, I was just looking at the utilization, I think it's come back down to like 4 or 5%, where it was like 15 in the pandemic, which I also was a little bit surprised. I was like, wow, 15%, I would have thought it was higher. But again, it's a little bit back to we were all in our houses, probably not thinking about, do we need to go to a physician, worried about a whole host of other things for obvious reasons, and fighting over toilet paper. So, but I think that's one where I would like to kind of see that tick up. Because for me, again, personally, and I'll contrast this with my parents, we both use telehealth. So I use telehealth as in, I have chronic migraines. I consult with my neurologist. I'm on a medication regime that's worked for me for years. I don't need to go into the office until I need something, that actually requires a change and requires an in-person visit. My father uses it in a very different way, but again, to keep tabs. Hey, I feel this. Is something wrong? Should I come into the office, right? So instead of kind of prompting that in person, he's actually, I say instead of Googling or WebMDing, he's calling the nurse practitioner to say, do I need to come in? It's 100% triage, right? And so both of those feel very valid to me. And again, to your point about limited capacity, and look, it's always limited capacity, right? There is not infinite capacity in the healthcare system. It allows the physician to be smart and thoughtful while also delivering a care experience and an outcome that's right for the patient.
I think that dovetails nicely with your comments about stratifying your patients or risk stratifying, because we can use that technology to reach out to people proactively, especially when you have a pandemic, they can't get out, or maybe they're rural or homebound. That's better than before when we had nothing until the ambulance showed up.
Exactly.
Metrics. You alluded to metrics. I definitely want to talk about metrics. I heard you say workflow and I heard you say outcomes, but for a long time we focused more, in the US at least, more in terms of processes, HEDIS type measures, for example. So can you talk a little about metrics, particularly process versus outcomes, the patient reported like PROMs or experience measures, PREMs. Are these things that you and your clients are looking at today?
So yes, and I'll say but. So I think the challenge that I still see is the debate around data. And when money is tied to data, that becomes infinitely more complicated. And I have sat on both sides of the table where there have been long debates on where'd you get those numbers? Why are those numbers included? How do you calculate this measure? This is how I calculate this measure. Why is it different? And so I do think back to a little bit of in the spirit of partnership, coming together, that is always going to be there. But I think that part of why I say coming together and admitting and understanding the gaps, strengths and weaknesses and gaps that you want to work on is so critical. So I agree. Look, admin measures, HEDIS measures aren't sufficient, but they are typically the easiest to measure, for better or for worse. So when I kind of come in and say, how are you performing? So first is just the stratification of the population, right? Do you understand the risk profile of your population? Do you then have care models or care teams that are aligned to that risk stratification profile? And I'm agnostic about how you think about that risk profile and the alignment of that, but I think that that's just a key part. I've seen physicians who truly do it on a whole population basis, which, hey, you're a risk score akin to MA risk scoring, which we can debate, but you have X number of clinical diseases, therefore you are a higher acuity, you are more likely to go to the hospital. So we have a different type of engagement model than my mother and father, who are probably a 1.0 senior and lower risk. I've seen it done on disease states too, right? We have high diabetic populations. We know that, and the other one is, depression, loneliness, kind of those things. And I've seen clinics actually kind of rotate around that to say, we're going to intervene on that, and we're going to have specific types of programs and interventions associated with that. So that's one. The other thing is a utilization, which is a little bit back to HEDIS, but in a different way. We like to see, if we're looking at kind of populations, PCP visits come up. We like to see specialty visits come down or more aligned with the underlying clinical disease states. We like to see hospitalizations go down. We like to see SNF utilization, hospice utilization for certain populations go up. So there is a site of care piece here that, as a payer, I'm looking at. More sophisticated providers also think about that, because for them, the referral patterns out are really important. Does the patient go out and come back? Or can I get to them if I send them to the hospital, right? If I determine that's the right thing, can I go and round there? Can I do the discharge planning with the hospital? Can I make sure that they get home? So that piece is important. And then From a quality perspective, yes, I think things like medication adherence for some of the HEDIS measures, to be perfectly fair, I think are an indication of outcomes, right? That you're managing to a set of outcomes through compliance or through some what we'd call process measures. And then on the consumer satisfaction piece, that's again one that I think is really important, but I don't think we have a great measure. NPS isn't a great measure, right? A Google review isn't a good measure. And, you know, depending on the line of business, and I always say Medicare is the one that pops, but I think we all do it. Who's your physician? Do you like them, right? So that word of mouth piece is another way in which we think about it. So I think, for better or for worse, honestly, managing the MLR in aggregate and by risk cohort is probably the way in which I think we kind of think through this. So, and the reason why I say it at the overall level and at the cohort level is you can have variation, right? Your MLR might not move for a certain population for a whole host of reasons, but you may be intervening in a way that's leading to better, you know, clinical outcomes, higher patient satisfaction, and they are just higher costs for the reimbursement that you're given. That's just the reality.
The discussion on outcomes versus process measures, it made me reflect on a conversation, one of these interviews with a colleague in the Netherlands who said, well, why would we do processes? That's like, my words, micromanaging. That's dictating to the clinician how he or she should provide care. All we really care about is the outcome. And I thought, that's all we really care about too in the US. We just think there should be standardized best practices. So thoughts on why we don't let's just do outcomes. Forget processes, utilization, all that. They'll find their own way there. We'll just measure outcomes. Why not?
So I totally agree with your colleague or the conversation. I think one is just the maturity of our clinical delivery in whole. And I think, look, the reality is even if you are a mature primary care physician practice under risk, you still are going to be doing some things under fee for service, right? It's not perfect. We are not in a fully value-based system. So part of the processes, I think, is to almost jumpstart how care is delivered and how care is coordinated. But you do see that these care teams are, sure, there is a daily huddle. So that is a process measure. We are daily huddling, and we have a standard way of thinking about which patients are huddled on versus which patients aren't. So that's a process measure, or that's a standard approach. What then happens in the huddle might be defined at the beginning as people get comfortable, but then I think, to your point, we trust that the care team can make the right decisions around the needed care, the needed intervention. So I think it's, again, a spectrum around how do you think about different things, and a maturity. Again, I think because process is so not easy to measure, but easier to measure, I think we are going to kind of default to that more until we feel like there is some maturity and a step change in how we all think about delivery of care under a value-based arrangement before we kind of start to think through, now we don't need to have such rigid definitions around kind of how we do things.
And in America, we've been measuring processes forever with the Medicare Plus Choice, right? And then Medicare Advantage.
Yeah.
And the pushback, as I heard it, was, well, physicians don't want to be accountable for outcomes because they only have so much impact. Thinking social determinants, genetics.
100%.
But that's true, but it's less true today than it was 20 years ago because we have data and we have processes. Yeah. And I think it's changing demographics and attitudes.
I think it's interesting if you look at South Florida in particular, which is a place where primary care-led value-based care is the model for Medicare and for Medicare Advantage in particular.
And commercial?
Not as much. And again, I think just from an adoption perspective, I've personally seen Medicare Advantage in particular, managed Medicaid, and then commercial. The heterogeneity of commercial members in terms of clinical needs and the variation, right? You could have a woman who's pregnant to a very healthy individual at any age to someone who actually has a chronic disease, you know, by birth or at some point in their life. So I think it's more difficult, in all honesty, to deploy those members or those models against commercial. Doesn't mean that it isn't happening, right? But that's kind of the progression that we've seen. But within Medicare Advantage in Southern Florida, Miami-Dade and Broward County in particular, you know, we have incredibly high Medicare Advantage adoption, 70%, which is highest, I think, with the exception of some parts of California. Culturally, you actually see an important component of those populations, right? They're more Hispanic in the populations within Medicare. Diversity, or that cultural importance, kind of infuses how the value-based care programs are deployed, which I think is really interesting. So to your point about what the doctor can and cannot do, I think there's a recognition of that, and also a recognition that if you don't understand kind of the cultural norms, the cultural flows, the expectations, and tap into that, you're going to be limiting yourself, right? And so that's another interesting part. Within that region in particular, you see much more community focus, which I think is just one of the unstated components of their long-term success.
I was just thinking about, like, in some Latin populations, the promotora idea. So is there somebody from the community, especially under a different payment model, where they don't have to be a billable professional? We've already been paid capitation or case rate or whatever. Let's get somebody who lives in the community, a little basic training, and they're reaching out to all of these abuelos y abuelas with chronic conditions who are a little more homebound, and we're worried about them. And they need better attention
100%.
Than historically we've done.
100%. And I think that's where you're starting to see, I'll say, pockets of innovation, for lack of a better term, in which we're saying it doesn't always have to be a clinician who's intervening. And that's...
It does if you have to bill in a traditional fee-for-service environment.
Exactly. And that's I'll just say a mental break, right? In the historical fee-for-service model into something different. And I'm an economist by training, and so my mind goes, well, if the resource costs less and you can deliver the same value, you should be thinking through that, right? You should align resource intensity with whatever intervention intensity. And you're right, the payment model 100% has to be aligned to that.